Hello, I'm Michael Marino, the Special Operations Battalion Chief for the Prince George's County Fire and EMS Department, and a Guidelines Committee member of the Committee for Tactical Emergency Casualty Care. I will be teaching you the guidelines and equipment involved in the first phase of TECC, Direct Threat Care. By definition, direct threat care is the medical actions that are performed when there is an external, ongoing threat to life, to you or the patient. The direct threat care phase occurs during operations in any area where there is a direct and immediate threat, not just the injury that has been sustained, but a continued external threat to life. Typical direct threat would include operations in the vicinity of known IEDs, an active shooter with clear lanes of fire at you or victims, an unstable or unshoored vehicle or structure, operations suspended at height or on a high line. In the direct threat care phase, very minimal medical intervention is warranted because the immediate ongoing threat to life is so high. Instead, the emphasis is on operational mitigation of the threat and evacuation to a safer area. Take a look at this scene soon after the explosions in the Madrid train bombing. Is this direct threat or indirect threat? The answer is that it depends on your individual perception of the threat. In this picture, there has been 1, 2, 3 explosions on the train. We've got dead people on the train and injured on the ground. There are no professional rescuers operating yet, and people are lying on train tracks. So is this direct threat or indirect threat? It could be a direct threat because maybe there are trains still active in the area. There is twisted metal and the potential for fire. Maybe there's a secondary or tertiary explosion about to occur. Maybe the terrorists are planning on initiating sniper fire on the rescuers. I may consider this a direct threat, but you may look at this and say this is an indirect threat because the explosions have already happened. The initial event is over. Essentially, there is no right or wrong answer here. The answer lies in how you individually, as a responder, perceive the threat. The goals during direct threat care are to accomplish the life-saving mission with minimal additional casualties, prevent the casualty from sustaining additional injuries, keep the response team maximally engaged at neutralizing the existing threat, such as disarming IEDs, containing or eliminating the shooter, shoring, fire suppression, whatever it is, and minimize additional public harm. The first step in direct threat care is to mitigate the threat and take cover if appropriate. Initiate actions to address the immediate life threat, whatever that is. Direct the casualty to stay engaged if appropriate. This may include advising an injured civilian to put pressure on their bleeding or to self-evacuate to safety. Always encourage self-aid if the injured person is capable, or buddy aid if there are uninjured persons in the immediate area. There are almost always uninjured or minimally injured civilians in mass casualty and high threat scenarios. You saw them in the picture I just showed from Madrid. These people are force multipliers and can be engaged to assist. You can tell people, put pressure on that, or help me pull this person out. In TECC, it's not the ABC algorithm we have always learned. During direct threat, forget about airway management. The extrapolated military data shows you are at much higher risk of death from bleeding. So, when you are in an immediate life-threatening situation, when there's an immediate threat to your life, airway management can be deferred until we get to a safer area. The only medical intervention that is warranted during direct threat care is to stop immediate life-threatening hemorrhage with a tourniquet. And that's only if it's feasible to do something based on the immediacy of the external threat to your or their life. Look at the bleeding and the amount of blood loss. If you feel that they're going to bleed to death before you can move them to a safer area, then apply the tourniquet immediately. If they're not going to bleed to death, then you can move them first, then put the tourniquet on when it's safer for you and the patient. Tourniquets in this phase should be hastily applied over top of the clothes and as high up on the limb as possible. Forget exposing the wound here. When you are under an immediate life threat, the most rapid way to control limb hemorrhage is to take control of the entire limb. We do this by shutting blood flow to the entire limb, even if the bleeding is distal. Apply the tourniquet in direct threat in only one of 4 places, high up on either arm or high up on either leg. That's it. Place it quickly in one of these 4 places, over top of the clothing. Tighten it down until the bleeding stops and then move that patient to safety. If there's no tourniquet available, or you are moving the patient first before applying because the threat is too high to do it right there, consider applying direct pressure, or, if possible, having the casualty or a civilian apply direct pressure while removing the patient. Every drop of blood counts. Immediately apply direct pressure over the major artery proximal to the bleed. You can do this by kneeling on these areas with your full body weight while getting the tourniquet in place. Although it may not stop the bleed, it will slow it down until we can get it completely controlled. Every drop of blood counts. Other than mitigating the threat and control of life-threatening bleeding, the other primacy in direct threat is immediate evacuation of the casualty to a safer area. If you cannot do that right away, consider quickly rolling the unconscious patient on their side into the recovery position. That will help to keep the airway clear while the casualty waits for evacuation. This does not mean to manipulate or control the airway. It literally means kick or push the patient onto their side if you cannot immediately evacuate to a safer place, and if it is feasible given the immediacy of the threat. Remember, the only medical care that is done during direct threat is tourniquet application, and then it's moved to cover. The extrapolated military combat data shows that external bleeding from an extremity is both the most likely injury and the most common cause of preventable death. Although we are applying this military data to civilian operations, it is the best information we have at present, so we're going to use that as guidance until we know better. So, early control of life-threatening hemorrhage is critical, and again, I emphasize it's not just any bleeding, it's life-threatening bleeding. How do you know the difference? I like to use the holy crap, that's a lot of blood rule. Pretty much if you walk up and you see the person bleeding and you think to yourself, holy crap, that's a lot of blood, this person is dying. That is a life-threatening bleed. However, if you look at it and it's not all that bad, that's fine. It's not life-threatening bleeding. So there is no definition of life-threatening bleeding other than you considering it to be life-threatening. Here's what we definitely place tourniquets for. Total or partial amputation, because total or partial amputations have a high risk of rebleeding. Typically, immediately after the injury, an amputation will not have a lot of bleeding due to vessel spasms. At some point, those vessels relax and the bleeding starts in earnest, and typically that occurs exactly when you least want it to. So any total or partial amputations should have a tourniquet applied during direct threat if it's feasible. And of course, any wound with very, very heavy arterial or massive venous bleeding should be treated right there. I want to emphasize to you that we don't use tourniquets to control non-life-threatening bleeding during direct threat care. We ignore the non-life-threatening bleeds in this phase. Yes, there may be massive tissue damage or a big wound, but if it's not actively and severely bleeding, we can defer its management until the next phase of care. Go for the bleed, not for the ugly. Again, in direct threat, we place the hasty tourniquet high up on the limb, proximal to the bleeding site, over the close. This is a great training picture because it demonstrates the need to go high and over the close for hasty tourniquets. If this person was wearing pants, you would not be able to see the small proximal bullet wound without full exposure. And remember, in direct threat, we don't expose or examine. You would only see the big bullet wound and bleeding in the back of the distal thigh. In standard EMS, you are trained to place a tourniquet as distal as possible. If you did that here without exposure, you would place the tourniquet below the small proximal wound that could continue to bleed. Remember, this is not standard EMS. How do we know where the wounds on the extremity are? Don't worry about it. Put the tourniquet as high up on the limb as possible, over the close, tighten it until the bleeding stops, and then move the patient. Most agencies and providers in the region are well familiar with tourniquets for rapid hemorrhage control. But to review, the truth about pre-made mechanical tourniquets is that they are fast and easy to apply. In the hands of someone who knows what they're doing, a tourniquet can be placed, tightened, and control bleeding within 30 seconds. Even when used by someone who doesn't know what they're doing, it's usually about a minute or so to get it on and get it tight. When using tourniquets, especially those applied hastily in direct threat, at every point in care after it's applied, consideration should be given to removing or downgrading it. The emphasis with hemorrhage control is that every drop of blood counts. Get the tourniquet on quickly at or near the point of wounding, because studies show that tourniquet survival is very, very good if it can be placed with good hemorrhage control prior to the onset of hemorrhagic shock. Survival is poor even with tourniquet use if the patient goes into class 3 or 4 shock. The safety profile for tourniquets is very, very good. The potential for tissue damage is related to how long the tourniquet is on. How long is too long? Multiple studies show that if the tourniquet comes off within about 2 hours, there is no increased compartment syndrome, no increased limb damage or loss, no neuropraxia or damage to the nerves. Those things may still occur, but they are mainly the result of the explosion of the bullet, not the tourniquet. After 2 hours, up to about 4 hours, there is about a 5% complication rate of neuropraxia, or damage to the nerve. But even the vast majority of those resolve over a 6-month to a year period. That is a long time, and it will be a rare scenario in the NCR where a tourniquet has to remain in place for that long. Even still, at every point of care after the tourniquet is applied, it should be considered for downgrade or removal. This is a study that emphasizes tourniquet use. This study is out of Iraq and looked at about 500 combat, blast, and ballistic casualties. The overall survival rate with tourniquet use was 87%. However, the survival rate in patients who went into hemorrhagic shock before the tourniquet was applied was only 4%. 87% if the tourniquet was placed right away, 4% if it was placed after onset of shock. Early application is key. Mechanical tourniquets are used to apply compressive pressure on the limb to occlude all distal and arterial and venous flow. The new versions, the ones we're using in the COG region, have either a 1.5 or a 2-inch strap to allow for wider compression forces across the tissue in an attempt to decrease tissue damage. Although all the tourniquets being used in the region are designed for one-handed self-application, that is not necessarily all that important. It is pretty cool to think of a dramatic scene where you pull out your tourniquet and strap it on your arm, saving your own life and winning the battle, but that is not all that realistic or applicable in the civilian setting. The point is, if they can be put on one-handed, they're easy to put on two-handed. So our tourniquets are all very easy to apply, and they all use mechanical mechanisms to apply occlusive forces. I'm going to review for you the most common tourniquets that are used in the National Capital Region. Let me emphasize, they all work. Tourniquets, when you look at them, are a bit like Ford versus Chevy. You drive a Ford pickup and you hate Chevy pickups. I drive a Chevy pickup and I hate Ford pickups. It doesn't matter. They're both pickups. They both haul manure, right? All the tourniquets work. They all have strengths and weaknesses, and one is not necessarily better than the other. You need to know the operational limitations of your tourniquet and train to overcome them. In this lecture, we are covering the 3 major tourniquets that are being used in the region for interoperability. As a provider, you should be familiar with all the tourniquets that are being fielded in the COG region because you never know which agency will be coming to assist you on game day. We will start with the Military Emergency Tourniquet, or MET. The Military Emergency Tourniquet is the most common tourniquet being fielded in Northern Virginia. It is very lightweight, and it's a true open loop system with unlimited strap uptake, which means it does not need to be fully seated on the limb before you start tightening. If you put it on loosely, by continually turning the windlass, the strap will continue to tighten. So, in the heat of the moment, if you do not place it perfectly, just keep turning it. It will eventually tighten itself down. It also has an aluminum non-breakable windlass. It's a very simple operation and can be applied in seconds. The one weakness with this tourniquet is that it is not as intuitive as some of the others, especially if you take it fully apart and have to route the strap through the base plate. This one has a little bit more of a learning curve, so train with it, but it's a great tourniquet.
The tourniquet selected for use by many of the COG jurisdictions is the Military Emergency Tourniquet, Generation 3. Some jurisdictions may also have earlier versions of the MET. All 3 versions operate the same way, with the only difference in the most current Generation 3 being the wider strap. The MET is an open loop tourniquet, meaning it can be taken apart all the way, so it can be placed around a mutilated or trapped limb without having to place it from the distal end of the extremity. The MET also has an unlimited uptake, sturdy metal windlass, and 2 locking points. The MET is ready to tighten once the strap is run through the end of the base plate and through the opening in the middle of the windlass. Place the MET in the desired place on the extremity, hold the base plate to the extremity, and pull the strap while holding the base plate in place. Once the strap is pulled tight, you start turning the windlass until you have reached the desired result. Remember that the end point of tightening a tourniquet is visual cessation of bleeding and absence of a distal pulse in the extremity the tourniquet is being used on. The windlass should be secured under one of the loops and then slid under the second. If possible, secure the windlass under the Velcro loop first, then secure the adjustable side. The adjustable side is larger and can be manipulated more to get the windlass to fit underneath.
The Combat Application Tourniquet, or the CAT, this is the one that is best known. It was the first true widespread mechanical tourniquet fielded in OEF, OIF. It is very lightweight and it's very simple to operate. It certainly can be applied and secured within seconds. One of the weaknesses of the CAT is that it's a closed loop system with only limited strap uptake. The CAT only has about 3 inches of strap uptake due to its mechanism. As the windlass turns, it draws 2 metal pieces on the base plate together. Once these pieces touch, the strap cannot get any tighter. This means that it must be fully seated, fully tightened, and properly applied on the limb before tightening. On an obese thigh, you may need to get 2 CATs side by side to get enough compressive forces because the limited uptake limits the amount of tissue compression you can apply. The routing on the strap through the buckle is another weakness. Although it may be routed through only half of the buckle, the tourniquet is most effective, especially on large thighs, by routing it through both sides of the buckle. Be aware that when the CAT comes out of the package, it is routed only through half of the buckle and thus must be adjusted prior to thigh or leg application. One additional thing about the CAT. Because it is so popular, because it has been used for so long, there are significant counterfeits being produced. So if you see a CAT tourniquet and it's offered for $5 or $10, it's a fake. It's a cheap made product that will break during application. All tourniquets run in the $20 to $40 range.
The Combat Application Tourniquet is perhaps the most common tourniquet currently in use throughout the country and was one of the first commercial tourniquets on the market. It is constructed of a Velcro strap and plastic windlass and locking point. There are several generations of the CAT, so users should make sure they have the most current generation of the CAT, which is indicated by a red tip on the strap and red tip technology on the instructions, along with a white time on the Velcro tab to secure the windlass. There is also known counterfeits of the CAT, so they should only be purchased from licensed vendors. There are several configurations to running the strap through the slats. When placing the CAT onto a patient, it is recommended to always run the strap through both slats. Velcro may fail if it gets saturated with blood or other fluids, or inadvertently comes in contact with carpeting or other materials. The CAT can be taken apart open loop, but has a limited draw and uptake. To assure that you are able to get as much uptake as possible, make sure to pull as much slack out of the strap and make it as tight against the limb as you can prior to turning the windlass. Once it is tight on the limb, turn the windlass until you get the desired result and secure the windlass under the hoop and close the Velcro tab.
The Soft T tourniquet, again, a very good tourniquet. It's being fielded by a lot of federal agencies in the NCR. It's also being used in a variety of places across the United States as well as in the military. It's lightweight, simple to use, and it's a true open loop system, very similar to the military emergency tourniquet, which means that you do not have to fully cinch it down. If you keep turning, the strap will continue to tighten, and it has a very strong aluminum windlass. The older version has an alligator clip with a small screw that must be tightened down, securing the alligator clip prior to tightening. The newest version, called the Soft T Wide, has a wide 2-inch strap and a metal buckle that is much easier to use. One of the weaknesses in the newer version is that it only has one point of contact, a single D-ring, to secure the windlass. Although it works well, during operations we consider 2 as 1 and 1 as none, so there is no backup.
Another common commercial tourniquet is the Special Operations Forces Tourniquet, or Soft T. The first generation Soft T has a narrow strap and alligator clip with a screw, and 2 plastic locking rings to secure the windlass. The Soft T is also an open loop tourniquet with good uptake. To use the Soft T, place it in the desired place on the extremity, either by sliding it over the distal end or by taking it apart. If taking it apart, feed the end of the strap through the alligator clip. Pull the strap tight against the limb. Be sure to set the locking screw to avoid unintentionally loosening the clip or having the strap backfeed when being tightened. Once the tourniquet is tight enough, secure the windlass with the rings on either side of the base plate. The Soft T Wide is a newer version of this tourniquet that replaces the alligator clip and screw with a break-apart buckle. The strap is also wider, which falls in line with the trend and recommendation for at least a 1.5-inch strap. To make room for the new buckle, one of the locking rings was removed, so the Soft T Wide only secures on one side. To use the device, either slide the tourniquet over the limb or take it apart and put it back together once over the desired location on the extremity. Pull the strap tight and begin tightening the windlass until the desired effect is reached. Secure the windlass under the D-ring. Some users will break apart the buckle several times prior to placing the soft T-wide in service to make it easier to open during an emergency.
The field expedient tourniquet. Especially after the Boston Marathon bombing, where they used windbreakers and t-shirts, the improvised tourniquet is being proposed by some as a first-line treatment for exsanguinating hemorrhage. However, what we're not getting out of Boston is the information that a lot of these field expedient tourniquets fail. Studies show that even in the hands of someone who knows what they're doing and does it all the time, improvised cravat and windlass tourniquets fail 40% of the time. It may work, but it is not reliable. Consider it only as a backup or last-ditch effort. If you run out of equipment, yes, you should try this. But we would much rather use something that fails maybe 5% of the time, such as the soft T or a CAT or a MET. One of the problems with the cravat and windlass is that you usually don't have this nice 6-inch pre-cut dowel to use as a windlass, and we gravitate towards things like leather belts or shoestrings for a strap. It is almost impossible to tighten a leather belt enough to achieve the compressive forces needed, and shoestrings or a t-shirt tend to rope, causing significant tissue damage and pain that prevents tightening. Thus, it just becomes a venous tourniquet. It doesn't stop arterial flow and may actually increase bleeding. The field expedient tourniquet, you need to be aware of it, you need to train with it, but understand that it is a last-ditch effort only. Using the military experience, here are some mistakes to avoid when using tourniquets. Not placing it correctly. Remember, in the direct threat phase of care, we want to get it high and above close, as high up as you can. No need to expose the wound. Get it high up, get it on in 30 seconds, and move that patient. Not tightening it enough. This is probably the most common fail point, and we've seen this in our region with civilians. The problem is that tourniquets hurt. So when the provider starts to tighten it down, the patient complains of pain and the provider stops, even though there is still bleeding. Tighten until bleeding stops and there is no distal pulse. Tourniquets are more difficult to use on the thigh than they are on the arm. The more tissue that must be compressed, the more you have to tighten. Using it when it's not needed. This, however, is a relative fail point because if you think you need one, put it on. That's the rule. But try not to overuse if possible. With an open fracture that's not bleeding, you don't need a tourniquet. With small, oozing distal wounds, you don't need a tourniquet. Although again, I would emphasize to you, you will never be second-guessed. If you feel that in this direct threat environment they need a tourniquet, put it on, because we have multiple points of interaction later on where we will be able to take it off. More mistakes to avoid. Removing it because of pain. If you put it on somebody, bleeding stops and they say it's painful, don't take it off. Instead, move them to a safer area in another phase of care and give them pain medicine. Do not stop the intervention because of pain. You use it until it's effective and then address the pain later. Failing to reassess, especially after moving. If you put on a tourniquet in a direct threat phase, it's hastily applied over the clothes. You're going to put it on quickly and move them to a safer area. If that bleeding restarts because the tourniquet got dislodged, retighten or replace the tourniquet until bleeding stops. So, the first thing you need to do at the next phase of care is check that tourniquet. Anytime you move a patient, you have to reassess the tourniquet. No reperfusion intervals. There was a sense back in the 80s and 90s if you used a tourniquet, you could do what are called reperfusion intervals by loosening the tourniquet to allow blood to flow through the limb for a second or two and then tighten it back down. Don't do that. It doesn't work. Remember, we've got roughly 120 minutes of tourniquet time. All you're doing when you do a reperfusion interval is losing blood. So no reperfusion intervals, that's a mistake. The last fail point we want to avoid is forgetting to use a second tourniquet if needed. If the first tourniquet does not work after placing it as tight as possible, place a second tourniquet next to the first. Proximal is preferred, but distal is okay. And tighten that one down. 2 tourniquets next to each other apply a wider base of compressive forces, and this will help to stop bleeding. In summary, when we talk about tourniquet use in direct threat care, indirect threat care, or evacuation care, with any tourniquet use, number 1, get it on before the patient goes into shock. Survival is much greater if we can prevent shock, and every drop of blood counts. Number 2, if the bleeding is not controlled, use a second tourniquet just next to the first. Number 3, the 1.5 to 2 inch width bands are a little bit safer. They have less tissue damage by a wider base of compressive forces. However, if you only have the 1 inch band, that's fine too. The ones that are being purchased now for the COG region are the newest versions with the 1.5 to 2 inch straps. Finally, let me emphasize this to you again. Tourniquets are safe. They are safe and they save lives. Besides dealing directly with the immediate threat and controlling life-threatening bleeding with the tourniquet, the other main emphasis in direct threat care is evacuation. Mitigate the threat, address life-threatening hemorrhage, evacuate. Rapid evacuation using the best body mechanics and lifting techniques you can to make the work as efficient as possible. You want to use the proper techniques because if you're the one that has to carry out a slew of plus-size adults from the bottom of a metro escalator, you're going to be glad that you used the right technique to do it. It will be less work for you. This is a picture from Virginia Tech. This is not a criticism of these guys. They did a great job, but this is an inefficient carry. You see 4 people here carrying one guy who probably weighs about 200 pounds, and they appear to be struggling. This is an inefficient carry. They did not do anything wrong, but we can learn from this. This from Virginia Tech is a more efficient carry. This girl probably weighs 140, maybe 150 pounds. There are 2 officers carrying her instead of 4 in the last picture. Here, the other guys have been freed up to take care of the threat or do something else. Use efficient body mechanics. Let me show you a couple and you'll learn these in your hands-on. Drags. 1 or 2 person drags with or without lines. You can certainly use webbing or skeds to move a patient. One of my favorite pictures is the one you see here, which was an active shooter event in a store. What you see is this one guy moving a patient using what he has around him. He grabbed a rug and used it to pull her out. That's what you use. Be creative. If there's a wheelchair there, grab it. That's what they did in the LA shooting. They threw the wounded TSA officer into a wheelchair. If there's a shopping cart, use it. If there's a desk chair that has wheels on it, you can use it. Use anything you can to move a patient as simply or as quickly as possible. Or just grab their hands and pull them out. This is called the Halls carry. And certainly you can, if you want to, play cowboys and Indians as well. You can take an injured person, drag them over your back, and carry them. The injured person has to be conscious and be able to help a little bit in this carry, but it's a quick way to move somebody a short distance away from the direct line of fire or away from an IED, around the corner to a safer area. This is another efficient carry because you share the load and the body weight of the patient that is carried across your shoulders on your vertical posture. It is good for very large patients or officers who are wearing gear. To do this carry, 2 rescuers sit the patient up, place his arms over their necks, grab the belt of the patient, and then a coordinated lift while walking forward, dragging the patient's feet. The key is using the belt or pants line as a lift point. This carry has a wide profile, so it is hard to use on stairs and through doorways, but you can move a heavy person a short distance. It's efficient weight distribution for you. The 2-person side carry, you all know this one. This is what you were taught in Boy Scouts. Make a chair by grasping arms with the second rescuer in a square pattern and have the patient sit on your arms. In this carry, the patient has to be awake and able to follow commands like a victim with an amputated limb. It's for quick, short movement only and is not effective for stairs or narrow points because you're very wide. The 3-man carry. If you are moving patients for a very long distance, the 3-man carry can move a large patient very efficiently and pretty quickly. Essentially, it's the 2-man carry with a 3rd rescuer carrying the legs. So sit the patient up, place his arms across the shoulders of the 2 rescuers, and perform a coordinated lift using the belt as a lift point. The 3rd man then comes up underneath the legs, placing them over his shoulders. Now the weight is distributed amongst 3 people. And what you find when you perform this carry is that it's really not that hard, even with the 250-pound patient. It does have a very wide profile, so it's very hard to go through doors. But once you get outside into an open space, you can move somebody relatively quickly with very little or minimal effect on you. Probably the one that you need to concentrate on as the best and most efficient for inside buildings is what is called the 4-aft carry. Narrow, single-person profile so you can easily move through doorways and can make tight turns with this carry. It's a relatively even distribution of weight, about 60 to 40. The person at the head has a little more weight, but it works pretty well. To perform this carry, the person at the head sits the patient up, reaches under the patient's crossed arms and grabs the wrists as the lift point. This is key. You must lift using the wrists. By doing this, the load is not on your arms and biceps, but is transferred to your grip. The person at the feet picks up the knees, not at the feet making them into a V, but at the knees. The 2 rescuers then perform a coordinated lift and start moving. This is a good carry. So that's it for direct threat. take a break. The next topic to be covered will be the next phase in the sequence, indirect threat care.